Hello, my name is Leslie Cooper. I'm the chair of cardiology at the Mayo Clinic in Florida. Today, we will be talking about cardiac sarcoidosis. I have no disclosures relevant to this presentation. Cardiac sarcoidosis was first described in a case report in 1929, and since then, most of the world's literature has consisted of case reports and small case series. A landmark study in 1952 by Longcope and Freeman described that 20% of patients who died with systemic sarcoid had cardiac involvement at autopsy. In the 1970s, similar autopsy-based studies revealed that about 5% of patients with systemic sarcoid had clinical cardiac involvement, but about 25% overall had histologic involvement. Thus, 80% of cardiac sarcoid was clinically silent. In the 1990s, the Japanese described the first clinical description for the diagnosis of sarcoid, and at the same time realized that the endomyocardial biopsy had a fairly low sensitivity for the disease. The Japanese criteria, first published in 1993 and revised in 2009, require two major or one major and two minor criteria to make the diagnosis of clinically suspected sarcoidosis. The major criteria include high degree atrioventricular block, thinning of the base of the septum, a positive gallium scan, or an otherwise unexplained decrease in the ejection fraction to less than 50%. The minor criteria include an abnormal EKG, an otherwise abnormal echocardiogram, unexplained perfusion defects on nuclear stress imaging, or the presence of delayed gadolinium enhancement on cardiac MRI. A biopsy that does not contain granulomas, which are diagnostic, but does contain scar tissue or isolated inflammatory cells known as monocytes, are also considered minor criteria. This echocardiogram demonstrates the typical findings of cardiac sarcoidosis. The midventricle is a bit hypertrophied, but has normal contractility. The base of the septum, seen near the top of the screen, is thinned and aneurysmal, moving away from the ventricle during systole. The valves, in this case, are generally normal. Cardiac sarcoid has a propensity for the base of the septum, as illustrated here in this figure from Dr. Rena Candelin's paper in 2015. Less commonly affected areas are the base of the atria and the free wall of the right ventricle. On occasion, the apical segment of the lateral wall can also be involved. Cardiac sarcoid generally requires the diagnosis of granulomas. In the bottom right panel, you can see giant cells in the middle of a well-formed granuloma surrounded by fibrotic tissue. At the bottom left, there is an area of inflammation that would otherwise be considered lymphocytic myocarditis, but in the context of sarcoid is an associated feature. Not infrequently, sarcoid has a high degree of fibrosis and few eosinophils. Sarcoid is relatively uncommon, but has a distinct presence in the Scandinavian, Japanese, and U.S. African American populations. Approximately 6 per 100,000 people and slightly more in male versus female patients are affected by sarcoid. The rate in the black population is approximately 2.5 times that in the Caucasian population in the United States. Clinically, between 2.5% and 5% of patients with systemic sarcoid will have cardiac involvement. This data from Hugh Fleming's work in the mid-1990s described the cardiac manifestations of sarcoidosis in 300 patients. The most common presentation were ventricular arrhythmias, often with syncope or sudden death. Less commonly were supraventricular arrhythmias, high-degree heart block, and heart failure. When heart failure presents in sarcoid, it is generally a subacute to chronic process. More recently, In Finland, the natural history of 110 patients was described by Rina Kandelin. In her series of papers describing sarcoidosis from 1988 to 2012, the average age was 51 years, and about 2/3 of the cases were clinically isolated to the heart. Without any kind of imaging or electrogram guidance, endomyocardial biopsy only had a 30% sensitivity. These data are consistent with previously studied patients in Japan. The majority of patients in Finland presented with a slowly progressive cardiomyopathy, but many had associated heart block or ventricular arrhythmias. Indeed, the risk of sudden death was about 32 out of 100 patients over 7 years. In this study looking at idiopathic heart block in patients under age 55, approximately 25% who underwent endomyocardial biopsy actually had cardiac sarcoid or giant cell myocarditis on the biopsy. This is a remarkable number and supports the practice of performing heart biopsy in patients with initially unexplained AV block. More recently, the Heart Rhythm Society has published an expert consensus statement on the diagnosis and management of arrhythmias associated with cardiac sarcoid. The diagnostic criteria are different than the Japanese criteria, which have existed since 1993. If a biopsy is not performed, then sarcoid may be diagnosed on the basis of an extracardiac biopsy, which diagnoses sarcoid, in addition with a steroid-responsive condition, a diminished and otherwise unexplained decrease in left ventricular heart pump function, spontaneous ventricular tachycardia, high-grade heart block, and a positive positron emission tomography, MRI, or gallium scan. Thank you.